Hi, I'm Stacy Rush. I'm doing my presentation on anxiety disorders with a focus on agoraphobia. Anxiety disorders are disorders that share features of excessive fear and anxiety-related behavioral disturbances. The difference between fear and anxiety is that fear is the emotional response to a real or perceived imminent threat, and anxiety is the anticipation of a future threat. Anxiety disorders differ by being excessive, persisting beyond developmentally appropriate periods. There are several types of anxiety disorders. They are arranged by the onset of age here. First, there's separation anxiety disorder, which is inappropriate and excessive fear of anxiety when separated from those that they care about or are attached to. There is selective mutism, failure to speak in a social environment where social speaking would be common. There's specific phobia. This is a marked fear or anxiety about a particular object or situation. There's also social anxiety disorder, the fear of an anxiety of one or more social situations where the individual may possibly face scrutiny by others. There's panic disorder, which is recurring unexpected panic attacks, a surge of intense fear or intense discomfort that peaks within minutes. There's agoraphobia, marked fear of anxiety in 2 or more of 5 specific areas. Generalized anxiety disorder is excessive anxiety and worry occurring more days than not for at least 6 months. Substance medication-induced anxiety disorder and other medical conditions. These are panic attacks or anxiety predominant in clinical picture. For medication and substance, the symptoms developed at the time or after the substance or medication use started. And due to another medical condition, they both have to have the ability to produce the anxiety disorder symptoms. So how do you tell the differences in the diagnosis of anxiety disorders? There are types of objects or situations that induce fear, anxiety, or avoidance behavior and the associated cognitive ideation. They can be differentiated by the types and situations that are feared or avoided and the content of associated thoughts and beliefs. So what is agoraphobia? Fear or anxiety in 2 or more of the 5 situations: public transportation, open spaces, confined spaces, being in lines or in a crowd, and getting out of the house alone. The diagnosis criteria is that the individual fears or avoids these situations due to thoughts that they cannot escape, help is not available if panic-like symptoms or embarrassing symptoms do occur. The person can actively avoid the situation, require someone to go with them, or face it with intense fear or anxiety. It must last for 6 or more months, causes clinically significant distress or social impairment in social work or other daily atmospheres. If other medical conditions occur, the anxiety or avoidance is excessive. If it is not better explained by another mental disorder, like only social situations for social anxiety disorder, and not obsessive perceived as flaws in personal appearance, or reminders of traumatic events, or fears of separation. If one meets the criteria for both panic and agoraphobia, both diagnoses should be made. The intense fear or anxiety triggered by a real anticipated exposure to these situations, symptoms must occur in at least 2 of the 5 situations. And when in these situations, people often believe that something bad may happen. The fear or anxiety is experienced almost at each time the individual is in the feared location or situation. If an individual experiences these symptoms only occasionally, like for example 1 in 5 times, the diagnosis would not be considered agoraphobia. If an individual actively avoids the situations by changing their behavioral patterns, their work, the way they get to work, transportation, avoiding grocery shopping, that is also a diagnosis criteria. However, the situation must be feared without other reasonable fears. For example, if using public transportation in a high crime area, if the person was experiencing fear or anxiety, it would not be agoraphobia because they had a reason to fear because of the high crime area. There are also cultural differences. For example, a Muslim female that does not leave the house alone would not be exhibiting symptoms of agoraphobia because that is the cultural norm. The brain function, the fear center or the fear center or amygdala is part of the brain that regulates fear, memory, and also coordinates these resources with the heart rate, blood pressure, and other physical responses to stressful events. There is some evidence that suggests the amygdala in people with anxiety disorders is highly sensitive and reacts with a high stress response. Statistics: 1.7 adolescents and adults are diagnosed with agoraphobia each year. Females are twice as likely as males to experience agoraphobia. The majority of people with panic disorders show signs of agoraphobia and anxiety before developing a panic disorder. The treatments. The most effective treatment for agoraphobia is cognitive behavior therapy. It is a hands-on approach to problem solving, and the idea is to change the way that the brain thinks, to retrain the brain, or as I like to call it, perform our own brain surgery. This is how we change the way a person processes thoughts and behaviors due to the way that they feel. It is a short-term and goal-oriented, which also makes it successful. It works by changing people's attitudes, thoughts, and behaviors by focusing on the thoughts, images, and beliefs and attitudes. We often tend to breathe faster when we are anxious, which can make you feel dizzy, lightheaded, and can make a person more anxious. One of the techniques is calm breathing techniques. It involves taking slow, regular breaths through your nose. And it is important to remember that it's not the goal to stop the attack, but it's the goal to be able to ride it out. We want the client to become aware of fear, identify their thoughts, and for example, they can try asking the following questions. What is so bad about this? What would that lead to? And what would happen if? You can take the answers to those questions and associate them with 2 types of generalizations: overestimating or catastrophizing. We want to be able to develop the physiological change in the brain so that the new thoughts and feelings become permanent. We want them to think realistically. There's also exposure therapy. It is based on having the person relax, then imagine the components of the phobia working from the least fearful to the most fearful. The client will begin to enter the locations or situations that produce the least amount of anxiety. When they are in that space, stay there until the anxiety decreases. This can also be done through counseling sessions, visualizing, or they also have virtual reality techniques to put the person in that situation. Medication is also used for anxiety disorders and agoraphobia. There are certain antidepressants called selective serotonin reuptake inhibitors, SSRIs. These examples are Prozac and Zoloft. There are also anti-anxiety drugs called benzodiazepines. There are sedatives, and they often provide temporary relief of anxiety symptoms. They're usually only given to relieve acute anxiety or short-term basis because they can be habit-forming. They aren't a good choice if you've had long-term history of anxiety or problems with substance abuse. Antidepressants are often more effective than the anti-anxiety medications, and both medications can cause severe side effects. You may have to use or try many medications before you find one that works properly for your body, and they can be habit-forming. When caring for those with agoraphobia, it needs to be stated that it can become so severe that a person would not want to leave their home without a caregiver or medication. If you can imagine the difference between I'm going to go for a walk or I'm going to try to take a step outside my door. Caregivers must be supportive and help establish little goals for them to accomplish. They want to take one step out the door and then continue maybe the next day taking 2 steps out the door. It's important to attempt to get to the target goal, but not push the client or family member too far. Another example would be if they're scared to go to the store, you would take them to the grocery store during a non-busy time of the day, and then work your way from there. Caregivers must understand it is not their role to cure the person, and do not get discouraged when they fall back or do not feel the desire to push forward. Communication is key when the individual wants you to step in and figure out what makes them feel most comfortable, because they need to take the lead and control of the situation. So obviously let them go as little or as far as they need to go, as long as they're doing it comfortably. You also want to alternate between caregivers. This will help prevent the burnout feeling. And you may also have to say no to whoever it is that you're caring for, because doing too much can also lead to burnout. And most importantly, don't belittle the way an individual is feeling or experiencing a situation with an anxiety disorder. Encouragement and empowerment is key. My spirituality, I actually suffer a lot of anxiety, so I often use this verse in my daily routine. Do not be anxious about anything, but in every situation, by prayer and petition and thanksgiving, present your requests to God, and the peace of God, which transcends all understanding, will guard your heart and minds in Christ Jesus. Philippians 4, 6, 7. And these are my references. Thank you. I hope you enjoyed my slideshow.